Good afternoon, good morning, good evening. We may be having so many people logging on from different countries. Thank you so much for logging on to our 4th ECHO session organized by the Ministry of Health, supported by SEED Global Health. So basically the topic we are going to talk about today is on hypertensive disorders in pregnancy. And we are really focusing on the approach to pre-eclampsia and other hypertensive disorders of pregnancy. My name is Nakatude Hadija. I am a midwife. I work with Reproductive Health Department, Ministry of Health, and I am going to be your moderator for today's session. So I want to give an opportunity to the experts to equally introduce themselves. I think we can start from Dr. Jackie, and then we go around like this. Over to you, Dr. Jackie.
Hi, my name is Jacqueline Akelo. I'm an obstetrician with Makerere University, but national coordinator for the Eclampsia subcommittee, NASMIC. Thank you.
Thank you, Dr. Jackie.
Hi, Dr. Ndozile Katari Jr., an obstetrician and gynecologist at Kawe International Referral Hospital. Glad to be here as well. Thank you.
Thank you, Dr. Ndozile. Yes.
Hello, everyone. I'm Dr. Isaac Chenemugera. I'm a student of Masters in Obstetrical and Gynecology under Makerere University.
Thank you, Dr. Chene. Over to you, Anita. Anita.
Hi, everyone. My name is Susasi Anita. I'm a midwife working in Mlago Specialized Women and in the hospital. Glad to be here.
All right, so thank you so much. That's the team of experts that we have today. Now, colleagues, we all know that hypertensive disorders are the second leading causes of maternal mortality, not only in Uganda, but worldwide. So there are so many issues that have been coming around during the reviews of MPDSR, and today, this team of experts is here to really address so many questions that come through, and I think you can mute. And we hope that your expectations will be met. So on the agenda, we want to run a short pre-test, which is going to take us around 5 minutes. And I beg that we can start on the pre-test. Kindly check on your screen. There are questions. There are 4 questions, and you can be able to tap on the right answer. It is just to assess your knowledge in management of hypertensive disorders in pregnancy. So colleagues, you can equally share your expectations when you're done with that chat, with the pre-test. But if you have a really burning expectation, you're free to raise up your hand and I'll pick up onto you so that you can air it out. Thank you. So we shall also have a Q&A session, and you'll be free to ask any questions, and the experts will be here to address your questions in the Q&A.
Please reshare the pre-test.
The pretest is on. Okay, you can go to more, then pretest, and you'll be able to see the pretest. So how much time do we have left? 1 minute. Okay, 1 minute left for the pretest. So we're putting it in. All right, it's time up for the pretest. We already have around 159 respondents, and thank you so much for logging on time and attempting the pretest. So colleagues, I urge all of us to continue putting our expectations in the chat. We shall be able to go through them. So we want to go straight to the next item on the agenda, and it's a patient case presentation, and it is going to be presented by Dr. Cheyune Isaac. And as he already said, he's a resident in the Department of OBGY, Makerere University. Over to you, Dr. Cheyune.
Kindly share the screen.
Okay. All right, colleagues, we are uploading the case presentation. So you still have an opportunity to write your expectations in that chat. But if also you want to air out your expectation, you're very free to do that. So some of the expectations that we have already, someone says, Stella, thank you for logging on, but she's saying that she needs to hear that key messages for non-medical persons. So I don't know whether we have any non-medical people logging on, but if yes, thank you so much for logging on. And I know we shall really have the key messages for the non-medical persons. Please keep the expectations coming. Okay, thank you so much for sending in the expectations. I think the presentation is now up. I want to hand it over the mic to Dr. Cheyune. Over to you, Doctor.
All right, so good afternoon, colleagues. Like I introduced myself earlier, I'm Dr. Cheyune Isaac, a resident from Makerere University in the Department of Obs and Gyn. Our case study for the day is a 26-year-old female who was a para 3+0 with postpartum eclampsia. So up on your screen are the brief demographics. She's NN, a 26-year-old female, admitted on the 11th of June at 05:10 hours. And the hospital of admission was Kawempe National Referral Hospital, particularly in the ICU unit. Tribe, she was a Muganda, Muslim by religion. Her address was Nama in Mukono district, and her next of kin was her husband. Next slide. So presenting complaint, this was history, collateral history from the caretaker, and the patient presented with convulsions for 3 hours. In the history of presenting complaint, so we noted that admitted is para 3+0, 6 hours post spontaneous vertex delivery referral from Mukono General Hospital, following persistent convulsions that started soon after delivery. Mother notably delivered twins. The first twin was a boy who weighed 2.2 kilograms, and the second twin was a girl, weighed 2 kilograms, and on her way, this delivery occurred on her way to a nearby private health center after having experienced labor-like pains for 8 hours while at home. Next slide. On arrival at the health center, it was noted that she had already delivered 2 live babies, and she had already undergone 3rd stage of labor with the help of her caretakers. Mother had also missed her last antenatal visit, and according to the husband, she had experienced mild headache, blood vision, epigastric pain, and lower limb swelling. Could you remove that, please? I beg your pardon. Okay, yeah, well, let's go back where we had begun. So I said, mother had also missed her last antenatal visit, according to the husband, and she had experienced mild headache, blood vision, epigastric pain, and lower limb swelling 1 month prior to this admission, for which she took Panadol and did not seek further medical assessment. 30 minutes upon arrival at the health center, she started convulsing. The convulsions were generalized tonic-clonic in nature, associated with frothing, upward eye deviations, and reduced consciousness. She was given an unknown injectable drug and then verbally referred to Mukono General Hospital, which also verbally referred to Kawempe National Referral Hospital without intervening. At admission, she was 3 hours post-delivery and had already experienced about 6 convulsions in total, with the most recent one right on arrival. ANC noted that she had booked from the same nearby private health center. The name has been withheld for confidentiality issues. At this health center, she had delivered 2 of her previous babies. She attended 2 visits, but the documentation of the visits was misplaced from home. Past obstetric history, she was a para 3+0. The first 2 pregnancies were both delivered by SVD. Both babies are alive and well. Firstborn 6 years old, secondborn 2 years old. She reported no history of hypertensive disorders during the previous pregnancies, and she had no intrapartum or postpartum complications reported. Past gyne history was unremarkable. Past surgical and medical history, we noted that she was PR or HIV seronegative, no history of chronic medical illnesses like diabetes. She had no history of hypertension. She was not on any chronic medications. She did not report any drug or food allergies, and she had no history of epilepsy. Noted that she had never had any surgeries or blood transfusions in her life before. Family social history, she was married, and noted that she had positive history of twins, her mother's side, and positive family history of hypertension on the maternal side. She was a non-smoker. She was not an alcoholic. She was married, and she was living with her husband, who was the father of all her children. She was also a peasant farmer, and that's what she was doing to earn a living. Examination findings at admission, we noted a sick-looking young woman, confused, febrile. She was not pale. She had anasaka. In other words, she was swollen all over. She was jaundiced deeply. Her blood pressure was 144 systolic and 103 diastolic. Her pulse rate was 105 beats per minute. She was saturating at 86% room air and 95% on oxygen by non-rebreather mask, 10 liters per minute. AVPU score, she was at P. The Glasgow Coma scale, she was scoring 12 out of 15. Motor was 5, eye opening was 3, and verbal was 4. Her pupils were equal and reactive to light. Her reflexes were intact, her neck was soft. Respiratory system, she was tachypnic, breathing at a rate of 28 breaths per minute with equal bilateral air entry. Cardiovascular system was normal. There were no added heart sounds. Her abdomen was of normal fullness, soft. Her uterus was palpable and well contracted at 20 out of 40. Vagina exam, we noted normal lochia, rubra, with no active bleeding per vagina. So diagnosis was made of a 26-year-old female, para 3+0, with postpartum eclampsia. What was done? This was the immediate care. She was positioned in the left lateral position. An oropharyngeal airway, particularly a model, was inserted and she was put on oxygen by non-rebreather mask at 10 liters per minute. We got IV access and took off blood samples for urgent lab tests. We catheterized and we noted thick colored urine, about 400 mils. A urine dipstick was done and noted proteinuria class 3. Please proceed to the next slide. Okay, so there you are. So we gave her magnesium sulfate, a loading dose, IV 4 grams of 20% solution. We gave it as a slow bolus of over 20 minutes. And then we gave IM magnesium sulfate as well, 5 grams of 50% solution diluted in 1 ml. Lignocaine on each buttock. So she got 10 grams in total of the IM. And then we prescribed the maintenance dose of 5 grams of 50% solution 4 hourly on alternating buttocks for the next 24 hours. And we admitted her in ICU. Noted, we prescribed ceftriaxone 2 grams once a day for 3 days, and nifedipine 20 milligrams once a day for 1 week, and methadopa 500 milligrams 8 hourly, 1 week. We got some labs. Our random blood sugar was 6.1 millimoles per liter. I already talked about the urine protein, which was +3. She had a negative slide for malaria. LFTs and RFTs, together with a complete blood count, was still pending at that review. So the ICU review, this was done 2 hours post-admission. The clinician in ICU noted the blood pressure of 161 over 118, pulse of 100, SpO2 94%. She was still on oxygen. Patient was not convulsing. Her GCS was 13 out of 15. Urine output was good, 100 mils in 2 hours. And the plan at that moment was to give IV labetalol, 20 milligrams slow bolus, and were meant to repeat the dose every 10 minutes until the diastolic was less or equal to 110. 3 doses were given in total. The post-resuscitation blood pressure had dropped to 144 out of 100 millimeters of mercury. So the plan was also to follow up on the lab chemistry. We inserted an NG tube for feeding and oral medication. Was supposed to monitor urine output on a fluid balance chart, monitor vitals, and continue magnesium sulfate as well. So day 1 review, 7 hours post-admission, we noted that she had received magnesium sulfate, 1 loading dose and 1 maintenance dose. Her convulsions were controlled. Her blood pressure was also controlled. At that point, the systolic was 110 and the diastolic was 70 millimeters of mercury. Her pulse was 82. She was saturating at 97%. She was on oxygen, this time by nasoprongs at 3 liters per minute. Her GCS had improved from the one at admission. Now it was 13. The admission GCS was strong. We also noted that she had urine output of 100 mils per hour, but it was dark and tea-colored. So some labs had come out. The complete blood count, the total white cell count was 11.5. Her HB was normal, 13.7 grams per deciliter. Significantly, she had a thrombocytopenia of 45,000 cells per microliter. Renal function tests, urea and creatinine were normal, high electrolytes were normal. Her liver function tests were also out. AST was 38 times elevated. It was 1,290.8. ALT was 9 times elevated. This is 9 times the upper limit. It was at 524.7. Total bilirubin was 2.5 times elevated at 51.9, and significantly the direct bilirubin. An impression was made at that point of a 26-year-old female, para 3+0, with eclampsia and HELP syndrome in view of the parameters listed above. So the plan was to continue magnesium sulfate, was to maintain on methyl dopa and nifedipine, to prescribe some IV maintenance fluids. That's 50 mils of dextrose 50% and 1 liter normal saline over 8 hours. Was supposed to give optimum nursing care, which included 2-hour returning of the mother in bed. Was supposed to monitor urine output on the fluid balance chart, as well as vitals. Day 2, still in ICU. Convulsions were controlled. She had been weaned off oxygen. Her blood pressures were equally controlled at 106 systolic and 70 diastolic, with a pulse of 108, saturating at 97% from air. Her GCS had greatly improved from 13 the day before to 14. It was only verbal where she was a bit confused, but motor was 6, eye opening was 4. Her urine output was still okay, 90 mils per hour. However, it was still T-colored. Renal function tests, urea and creatinine were normal. Liver function tests, AST was still elevated, 18 times the upper limit. ALT was 235.5, which is 4 times elevated. She had a low albumin count of 23.3. CBC, HB was 11.1, platelets were 67, urine protein on dipstick was still +3, and we had planned to continue treatment. Day 3, the intensivist in ICU noted significant clinical improvement. She had not convulsed for the last 48 hours. GCS was 14 out of 15 with some confusion. She had no focal neural deficits. Urine output was 100 mils per hour. Blood pressures were controlled, 124/81. Pulse rate was 80, saturating at 97% from air. So the plan was to repeat renal function tests and liver function tests the next day. Was supposed to continue oral feeds though the NG tube had been removed. The intensivist noted that there was no need of doing a brain CT scan since the patient had improved neurologically and was supposed to continue antihypertensives. That was day 3. Day 4, still in ICU. She had great improvement, was well oriented in place and person. She was clinically stable, febrile, she was not pale, she was well hydrated. BPs were within normal ranges, 138/87. Pulse was 80, so she was saturating at 98% from air. CNS, AVPU, she was alert. GCS, she was scoring 15 out of 15. Her pupils were equal and reactive to light per abdomen. The uterus was contracted at 16 out of 40, now non-tender. She had normal lochia on VE. Urine output was still okay. So the plan was to transfer to high dependency unit. We're supposed to do CBC, RFTs, LFTs, urine protein, continue methyl dopa, and nifedipine. Day 5, day 6, this was in HDU. The consultant in that unit noted that the patient's blood pressures remained controlled. She remained fully alert and conscious. However, on day 5, she developed an episode of generalized tonic-clonic convulsions, which episode lasted about 8 minutes. She was reloaded with magnesium sulfate and given IV diazepam. The seizures were controlled. Her RFTs had worsened. Creatinine was 4 times elevated. Urea was 5 times elevated, the upper limit. AST had improved a bit, but still high, 10 times elevated. ALT was 5 times elevated. Urine output had dropped 50 mils per hour, and then later dropped further to 25 mils per hour. However, the color was clear. So the impression was eclampsia with HELP syndrome and possible acute kidney injury with an impression of hepatorenal syndrome. The plan was to transfer the patient to Chirudu National Referral Hospital to consult the physician plus a nephrologist to assess the patient, as well as recommend the need of a brain CT scan. So that table is a summary of her clinical and lab parameters as follow-up on the subsequent days. Today is 21st. Significantly, this patient has greatly improved. We got in touch with her physicians in Chirudu. They did a brain CT scan. There was no lesion in the brain. She did convulse again for the last 3 days. Her renal function tests and liver function tests have greatly improved. Her creatinine is now within normal ranges. That is as of yesterday. Urea is also normal. So they found no need of doing dialysis. She was discharged last evening home. She's meant to come back for review a week later. Thank you very much for listening to me.
Wow. Thank you so much, Dr. Cheyune, for taking us through that near miss, near miss. Yes, thank you so much. It's really been a whole learning session. I was trying to understand what the team went through and also brings in issues of what it must take to have a functional CMOC facility, because I believe if that mother was not in your facility, probably she might have died. So colleagues, after Dr. Cheyune taking us through the case, we want to just dive into the overview and classification of pre-eclampsia, but kindly keep the questions coming. And I know Dr. Jackie is busy answering some of them, okay? Yeah, so at this point, I want to hand over the microphone to Dr. Ndozire Jr. Okay, fine.
They can ask.
Okay, so we can have 2 questions from the audience. You can please raise up your hand. Oh, we don't have any, apparently. Okay, I can see there's a question here, says, why wasn't the GFR done? Is AKI diagnosis based on urine output or creatinine? That is a question from Arik. And then there's also a question here. What causes a decrease in platelet count, actually? What causes a decrease in platelet count? So I think, doctor, you can be able to, you answer later.
Physiology.
Oh, okay, fine. Okay, thank you so much. So right now, we want to dive into the overview and classification of pre-eclampsia. Over to you, Dr. Ndozire.
Thank you very much. Able to have the presentation.
So as they're putting up Dr. Ndozire's presentation, I know there are so many midwives who are on the call, but I noticed one of the questions that usually comes through is we usually think when the placenta is out, then the mother is not prone to getting eclampsia. But then when we see in this case, babies were delivered, placenta was out, and then the mother got eclampsia. So probably that's a thing the experts will help us highlight. Why has the disease now changed? Okay. So over to you, Dr. Ndozire.
Thank you very much. Once again, I'm Dr. Ndozire Katari Jr. And we can move forward. This is going to be our presentation outline. We'll have a general overview of pre-eclampsia, and then and other hypertensive disorders. Then we will go through the classification of hypertensive disorders, and then we'll talk about the risk identification. So to start with hypertension, because we're talking about hypertension, basically means high blood pressure, or when the pressure in your blood vessels is too high. When we go into measurements, that is above 140 for systolic pressure and above 90 for the diastolic pressure. So we can still continue and classify this if the blood pressure goes beyond 160 for the systolic and 110 for the diastolic. That is severe high blood pressure. It's not pre-eclampsia, it's severe high blood pressure. Now, for us to say that you actually have a high blood pressure, we must have taken this blood pressure twice, at least 4 hours apart, okay? Sometimes in our settings, we are not able to do this because the patient comes with a blood pressure of 160 or 170 over 120. You really don't have time to wait for this patient so that you can confirm. But if the blood pressure is 140 over 90, kindly take this blood pressure again when the patient is relaxed. If you can go to the next slide, we're able to see how blood pressures are taken. Kindly move to the next slide. Yes, the patient should be seated with the feet on the ground. Can you go back? Thank you. Back. Yes, so the patient should be seated comfortably. The arms should be resting on a table, and the feet should be on the floor. And this is how you take the blood pressure. Or if the patient is not ambulant and they're in bed, they should be lying in bed and comfortably so. So basically that is about high blood pressure. So now we shall go into pregnancy in induced hypertension or hypertensive disorder of pregnancy. Next slide, please. Okay. All right, hypertensive disorders of pregnancy are among the leading causes of maternal and fetal morbidity and mortality. One of the reasons we really need to be talking about this because we have lost many women to hypertensive disorders. Those who have not died have ended up with conditions that have made their lives later difficult. Some have lost their babies severally. And so this is a very important thing for us to talk about because we can identify, we can manage. And so our efforts to promote prevention, proper diagnosis and treatment are really needed to reverse this trend. So there are 4 major hypertensive disorders that we are going to be talking about. And the first is chronic hypertension. We have the next slides talking about this. Gestational hypertension, pre-eclampsia, eclampsia, and HELP syndrome. Basically, those are the pre-eclampsia syndromes. Then we have pre-eclampsia, which is superimposed onto chronic hypertension. So in the statistics, we know that our maternal mortality has been reducing over the years. Currently, we have around 228 maternal deaths per 100,000 live births. And the second leading cause of these deaths is actually hypertensive disorders after obstetric hemorrhage. So, and when we look at these trends in our hospitals, like in Kawempe National Referral Hospital, the trends for the last 1 year, we are seeing that hypertensive disorders are slightly taking over the obstetric hemorrhage as cause of maternal mortality and morbidity. And now, it does not stop there. The cost of treating a patient who gets hypertensive disorders to the government is quite high. And because of this, it is very important for us to talk about because sometimes we are not able to have these tests done because the cost is high. Sometimes the patients need ICU. All this is very important for us to know. Now, when we go forward in the classification, we have put that table. So we have normal ranges of blood pressures. If you have a blood pressure of systolic between 9 and 139, and a diastolic between 60 and 89, that is a normal blood pressure. For chronic hypertension, we have more than 140 and diastolic more than 90 in a patient who is less than 20 weeks of pregnancy or who is not, yes, so that becomes chronic hypertension. Then gestational hypertension, blood pressure is above 140 and systolic and above 90 diastolic in a patient who's at least 20 weeks of gestation. However, no features of preeclampsia that we're going to look at later, no proteinuria, no systemic signs and symptoms. Then if for us to say we have preeclampsia without severe features, you have a blood pressure above 140, but not more than 160, so less or equal to 159, and a diastolic 90 to 109 after 20 weeks of pregnancy, but when you have proteinuria. Now, in an event that you're not able to have the proteinuria, you can still make this diagnosis without the proteinuria if you have the other features that we're going to look at. Then preeclampsia with severe features, blood pressure is above 160, above for systolic and above 110 for diastolic. And then we have organ dysfunction. We are still going to look at all those things. This is just a summary. Then eclampsia, where if you get a convulsion that cannot be explained by anything else, then we say we have eclampsia. And then HELP syndrome is where you have, someone might have high blood pressure or not, then you have elevated liver enzymes, then you have low platelets, and we might say that you have HELP syndrome. Let's continue. So the first thing is chronic hypertension. So we make this diagnosis if we have a patient before 20 weeks of gestation, the hypertension is diagnosed during pregnancy and or might persist for at least 12 weeks post-delivery. So if a patient comes to you, they have probably 14 weeks and they have an elevated blood pressure, we think this is chronic hypertension. Most likely they've already had, they had this hypertension before they got pregnant, or just chronic hypertension. Or if the patient delivers and then 12 weeks, which is around 3 months, after delivery, they still have the elevated blood pressure. We term this as chronic hypertension. Now, this can be either essential or secondary hypertension if we go on and investigate this kind of high blood pressure. And then next slide is gestational hypertension. We have new onset of hypertension after 20 weeks of gestation in a previously normotensive individual. So someone has not had high blood pressure before, but then after 20 weeks, they get a sudden onset of high blood pressure. And one, we do not have proteinuria in this patient. We don't have any severe features, which we shall talk about later. No severe features of preeclampsia, no evidence of end organ damage, okay? And that is, we do not have thrombocytopenia, we don't have any signs of renal insufficiency, we don't have elevated transaminases for the liver. We do not have pulmonary edema, cerebral or visual symptoms are not there. We term this as gestational hypertension. Next. So pre-eclampsia. Pre-eclampsia is a multi-system progressive disorder, which is characterized by new onset of hypertension after 20 weeks, or in the postpartum period. I think someone asked a question about why would someone get preeclampsia in the postpartum period. We are going to talk about that. So someone can get it after 20 weeks and after they have delivered still. So previously, this woman is supposed to be normotensive. If they were not normotensive before, then that becomes another diagnosis that we're going to look at. So on top of having those, your 20 weeks, you're previously normal, you have got a new onset hypertension, then you also get proteinuria that we we're supposed to calculate by getting a 24-hour urine collection, which is sometimes difficult in our settings. So we get what we call a urine dipstick reading of more than 2+. We say that person has preeclampsia. Or now, previously, proteinuria used to be it must be there for us to say it's preeclampsia. Currently, we do not need to have proteinuria. So a patient might have high blood pressure at above 20 weeks, and we might do urine protein and it's negative. But then they have the other signs of severe features. For example, they might have thrombocytopenia, they might have signs of renal insufficiency, they might have pulmonary edema. This person is also classified as pre-eclampsia. Let's continue. So when you look at this slide, we have the current classification that we use and the previous one. Previously, we would say mild, severe preeclampsia, depending on the blood pressure and the other features. But at the moment, we say preeclampsia with severe features or preeclampsia without severe features. So the one that we used to call mild is preeclampsia without severe features. The one that we used to call severe preeclampsia is preeclampsia with severe features. Next. So we can still further classify preeclampsia based on timing or of onset. So we can say this is early onset preeclampsia if the patient gets high blood pressure before 34 weeks of gestation. Or we can say late onset preeclampsia if this happens after 34 weeks of gestation, or based on gestation age, less than 37 weeks, which we know is term. So that becomes preterm preeclampsia, and above 37 weeks, that becomes term preeclampsia. Then we also have what we call postpartum preeclampsia. So that is still further classifying preeclampsia. Let's proceed. So now we have preeclampsia with severe features. So you have any of these findings that we talked about in the preeclampsia class, plus a systolic blood pressure above 160 and a diastolic blood pressure equal or above 110 on 2 occasions. I started by giving how this is done. So we say 4 hours apart. Most people don't do that, but it's important for us to rule out other causes of a raised blood pressure like white coat syndrome. So if also you have a doubling of serum creatinine concentration in the absence of other renal disease. So we also know that sometimes women can come when they already have a pre-existing renal disease. So if you rule that out and you're sure that the creatinine is because it has just happened, then that fits in our diagnosis. Or if someone has impaired liver function, as indicated by elevated liver transaminases, at least twice the upper limit, or if they have severe persistent right upper quadrant pain or epigastric pain, which is not responsive to most medications that we usually give, and it cannot be accounted for by any alternative diagnosis or both. So if someone has those, in the case that was presented, we realized that the patient had, I think, over 16 times elevation of the liver enzymes. Yes, so that fits in this criteria. So progressive renal insufficiency, if you have a creatinine of more than 1.1 milligrams per deciliter or above 90 micromoles per liter, this patient has preeclampsia with severe features. Let's go on. Also, if you have a thrombocytopenia, so if you do a complete blood count and then you have platelet count of less than 1,000 with or without DIC or without hemolysis, there are clinical signs that you can use to see whether the patient is hemolyzing or not. In the case presentation, we saw the patient had tea-colored urine. That's one of the signs that you can know that someone is actually hemolyzing. So with or without that, if you have less than 1,000 platelet count, then if you have signs of pulmonary edema, someone comes and you do their SpO2 and it's less than 90, they have difficulty breathing, they fit the criteria for severe features. Someone has persistent cerebral or visual disturbances. They can have photopsia, they can have blood vision, they can have severe headache. Usually patients describe this as the headache they've never had before. It's very severe. And most times it's persistent and does not respond to the common analgesics that we give. So this fits our criteria. And sometimes patients might also present to you with altered mental state. So this also fits the criteria for making a diagnosis for preeclampsia with severe features. Now, the other thing that we also look at these days is if there are signs of uteroplacental dysfunction. So if a patient comes and you do an ultrasound scan and there are signs of fetal growth restriction or an abnormal umbilical artery Doppler waveform, or they come with a stillbirth that cannot be explained by anything else, they might have preeclampsia with severe features. Let's go on. So the other classification is chronic hypertension with superimposed preeclampsia. We already talked about chronic hypertension. We have said someone has a raised blood pressure before 20 weeks, or it has been there, it's pre-existing. But if someone has had chronic hypertension, but all of a sudden they have an increase in the blood pressure that was previously well controlled, they might have preeclampsia. Or if you need to escalate the antihypertensive therapy to control the blood pressure, this patient might have a superimposed preeclampsia on their chronic hypertension. Then we also have new onset of proteinuria in this patient, or a sudden increase in proteinuria in a patient who has been having proteinuria before or early in the pregnancy. Yeah, so it is very important for us to get the diagnosis correct, because the treatment depends on the diagnosis. Because if you get a patient, for example, they are 32 weeks, you wrongly make a diagnosis of preeclampsia with severe features, you will end up delivering this baby. Then there are complications of preterm delivery that you're going to have, you're going to put on the baby. And so we really need to know exactly what we are doing. So chronic hypertension is superimposed preeclampsia with severe features. So the same thing, you have chronic hypertension, but then the patient gets a systolic BP of more than 160 and a diastolic of more than 110, despite the escalation in antihypertensive therapy. Then they also have thrombocytopenia. They have all the other signs of preeclampsia with severe features, like elevated liver enzymes more than twice the normal, the normal range, or they have severe persistent right upper quadrant pain or gastric pain unresponsive to medication, and cannot be accounted for by any other diagnosis or both. So these get chronic hypertension with superimposed preeclampsia with severe features. Let's continue. So if you have new onset worsening renal insufficiency, pulmonary edema, persistent cerebral or visual disturbances that we talked about, yes, this patient still fits the criteria. Let's continue. So if a patient gets an episode of conversion, generalized tonic-clonic seizure that cannot be attributed to other causes. There are other causes that we know can have. You have malaria, you have electrolyte imbalances. There are other things. If someone has epilepsy, so this patient is classified as eclamptic. So some mothers might have a normal blood pressure after a conversion. So this does not take them away from a diagnosis of eclampsia. And they believe that preeclampsia progresses from mild to severe to eclampsia is not always true. Sometimes you can have a patient and the first sign they give you is a convulsion. So we have to be careful not to miss it. Also, mothers can convulse without warning, or if even when they do not have severe blood pressures. Let's continue. So, HELLP syndrome is the other thing, it's also a subtype of preeclampsia, where you can have signs of hypertension, signs of CNS dysfunction, and renal dysfunction may also be present. But the feature that puts the patient into HELLP syndrome is you have signs of hemolysis, we have elevated liver enzymes, and we have low platelets. So if a patient has those three things, then they go into criteria of HELLP syndrome. We are going to look at the management later. So a slight snippet into the pathophysiology, which I'm not really going to delve into a lot, but basically we have a defective placentation. So normally during pregnancy, when the placenta is being formed, there are things that are supposed to happen. We have the placental vasculature that invade the decidua, and if we fail, if the spiral arteries fail to dilate so that we have good blood supply, we are going to get issues of hypoxia. We're going to get underperfusion, hypoxia, ischemia, and then we shall release factors that will go into the bloodstream and cause systemic vascular damage that then will be responsible for the hypertension that comes from the placental bed. So I'm really not going to get into this because of time. Let's proceed to the next slide. But we'll share this. Just the same, let's proceed. So quickly, let's go to the next slide. Quickly, I'm going to look at the risk factors for preeclampsia. So there are women who are at high risk of getting preeclampsia in our societies. And there are those who have high risk factors, then we have moderate risk factors. So I'm going to start with the high risk factors. So if a woman has had preeclampsia in the previous pregnancy, they are 8 times more likely to get preeclampsia in the subsequent pregnancy or in the current pregnancy they are at. And especially if the preeclampsia previously was early onset with an adverse outcome. So you really must take good history to get this out, tease this out. So multiple gestation. So if a patient has more than one baby, if you're carrying twins or triplets, they're also at an increased risk of getting preeclampsia, probably because the placenta is very big. So we have defective, defective placentation because of that. Then if someone has chronic hypertension, they already have a pre-existing condition. They have hypertension or they have type 1 or type 2 diabetes mellitus. These conditions affect the vasculature. So because of that, they are at a very high risk of getting preeclampsia in the pregnancy. Or someone has chronic kidney disease, they're also at a very high risk. So if someone also has an autoimmune disease, for example, someone has ALS or antiphospholipid syndrome or systemic lupus erythematosus, they are also at a very high risk of getting preeclampsia. Now, in the other category of moderate risk, we realize that women who are nulliparous, woman who has not had any children before, has a very high risk of getting preeclampsia. And actually, it occurs mostly in the women we call prime gravidas. It's their first time. Then we have, there's an explanation for that, something to do with the antigens from the father or from the sperm donor. So obesity is another thing. If a woman has a body mass index of more than 30 kgs per meter squared, is likely to have a high risk of getting preeclampsia. If someone has a family history, so there's a genetic correlation. If your mother had preeclampsia, or if you have a first degree relative, your sister has had preeclampsia, there's a high risk that you might also get preeclampsia. Then if someone has previously had an adverse event or an adverse outcome, for example, they've had a stillbirth or fetal growth restriction in the previous pregnancy, or they just got a braccio placenta, there's a syndrome that encompasses this that also involves preeclampsia. So they're also at a very high risk of getting preeclampsia in the next pregnancy. Advanced maternal age, as we age, we tend to get cardiovascular diseases that might also predispose us to preeclampsia. Then if you take a very large interval between your pregnancies, if the interval is more than 10, this increases your risk of preeclampsia. And actually, some studies show that, because we also say that if you change your partner, for example, your first baby, you have a different man, second pregnancy, you have another man, you're also at another risk of getting preeclampsia. But there are some studies that say that this correlation between changing of partner and preeclampsia might be because people take a very long interval to get pregnant, and that might be related there. In patients who get in vitro conception or IVF, who get IVF, whether with their own egg or with a donor egg, they're also at an increased risk of getting pre-eclampsia. Thank you for listening.
Oh, thank you so much, Dr. Ndozire, for that very wonderful presentation. And I saw so many questions coming through, and I hope at the right opportune time you'll be in position to answer them. But they can ask now. Okay, yeah, sorry about that. So we shall have the questions at the end of the session. So we want to have all the presentations at once. So right now, colleagues, allow me call upon Dr. Jackie Akelo, and she's going to walk us through the management of preeclampsia. Madam PET, over to you.
Thank you, moderator, and thank you, Dr. Ndozire, for the presentation. So lots of questions coming in. Remember, let's also be a little patient. There are things that are ahead about management, risk factors, and mixing magnesium sulfate. But then we will give those answers. So I'm briefly going to talk about management because we are going to do the practical demonstration about this management. So I'll be a little brief, but just to recap using that picture, what Dr. Ndozire has presented. For me, the take-home message is for us to be able to identify these patients from our antenatal clinics so that we can manage them timely and prevent complications. We don't want to reach where this mother reached to the point of having acute kidney injury and HELLP syndrome. If we can identify early, and that picture there just tells you the symptoms, if you can just remember that chart. To remember to take blood pressure in antenatal, remember to take the mother's weight and interpret. And when we say take, we really want to take and interpret. And the way we interpret these results is in relation to the previous reading or the first trimester reading. So you don't take blood pressure and document and say it is normal without looking back at the previous blood pressures. The headache, the blurry vision, all these are symptoms used to classify, like my colleague already talked about. So now after you classify whether preeclampsia with severe features or preeclampsia without severe features, those are the two classifications we have, or eclampsia. So preeclampsia with severe features, preeclampsia without severe features, and eclampsia. Then you decide on the management. So I'll start with the left arm, the yellow chart. So there you have preeclampsia without severe features. And someone was asking, how do we differentiate this? I saw in the Q&A from gestational hypertension. The difference here is only in presence or absence of protein in urine. So you have raised blood pressure, but no protein in urine. After 20 weeks, that is most likely gestational hypertension. The moment you get protein in urine, no symptoms, preeclampsia without severe features. However, there's a very thin line between the two, and usually one will always end up in the other. So that patient goes for routine care, and admit you, if you're in a health center 3, that's a high-risk mother. The moment you diagnose preeclampsia, that's a high-risk mother, even if she doesn't have severe features. So you want to refer this mother to a high-risk clinic in a CMOC site, so that the antenatal care now is done from either health center 4 or hospital level, and the delivery plan is made from that level of care. So that's the arm, and the care is, you see them in antenatal weekly, and each week that they come, you have to take their blood pressure, you assess for symptoms, you have to do laboratory investigations. Again, just to emphasize that you cannot commit to say a patient doesn't have preeclampsia without severe features, unless you've done a good history, a good examination, laboratory investigations, and a scan. All done, and then you can commit and say the patient does not have severe features. Because like Dr. Ndozi already said, you can have just intrauterine growth restriction and high blood pressure, and that's already a severe feature on scan. So you must do all for history, examination, investigation, which includes labs and a scan, and then you can commit and say this patient does not have severe features. And that's why I'm emphasizing for lower health facilities, the antenatal continues in a CMOC site, and those are the things you do. And again, to emphasize, irrespective of signs and symptoms, you diagnose a mother with with preeclampsia, delivery is at 37 weeks. If I come today at 37 weeks and you diagnose me today, I have to go home with my baby delivered. So that's the yellow arm of the chart. Now, if I go to the red side, I'll just go to the next slide to explain the rest. So that's just to emphasize what I already talked about. You have to carry out all those 4 before you commit. Next slide. So initially we had 3 goals of management, which were prevention, controlling seizures, controlling hypertension, delivery of the baby, and then now we have 5 because we are seeing a lot of recurrence rates, but also we want to prevent. I saw some questions in Kalisham, and we'll talk about prevention later on. But so now we have 5 goals of management. Prevent or control seizures, control hypertension, delivery. We know that the definitive, and again, this I'm saying with caution because we've seen mothers in the postpartum period developing preeclampsia like this one that was presented. But we know that placenta needs to come out, but you cannot come out with the placenta and leave the baby. So delivery is still part of it. And then of course, long-term prevention of recurrence. So let's look at goal 1, which is prevent and control. In the Q&A, some people asking about use of diazepam. Well, we do not recommend the use of diazepam, but if the mother is actively convulsing and you don't have magnesium sulfate, you are allowed, according to the BMOC training manual, and I'm referring to BMOC because that is expected at the level of health center 2, 3. You're allowed to use diazepam for a mother who's actively convulsing, and then you refer to the CMOC site. Because we know diazepam will cause respiratory depression in both the fetus and the mother. So you don't want to maintain this mother on diazepam. So our drug of choice is magnesium sulfate. This trial was done in Uganda, in Mulago, and the trial was actually halted based on results from Mulago. So we give it in terms of loading dose and maintenance dose. I'll not overemphasize this because Anita is going to talk about it and demonstrate how we mix, but the loading dose is 14 grams, given 2 doses, 2 routes, and 2 concentrations. Just remember, 2 doses, 2 routes, 2 concentrations. Total of 14 grams. 4 grams given IV, 20%. That is the first route is IV. The dose is 4 grams, the concentration is 20%. We shall do the mixing later. And then the other route and dose is 10 grams, given as IM of 50%, but the 10 grams is given in both buttocks, so 5 grams, with 2% lidocaine. I know I might be speaking a little too fast, but I'm going so because we have a practical session on that, so we can skip that. So total loading dose is 14 grams, 2 routes concentrations and 2 dosages. Next. Then we do maintenance. Oh, somebody says my volume is Okay, then we do maintenance. So you give a total loading dose of 14 grams, and then maintenance is 5 grams or 50% with 1 ml of 2% lignocaine every 4 hours on alternate battles. Colleagues, if you've not yet suffered from pre-eclampsia, I don't know if I should pray you should suffer so that you experience it, or you should not go through it because it's really painful. And a month ago, I was in a facility where they didn't give this maintenance dose because they didn't have just lignocaine. Lignocaine was in theater, they failed to bring it to local. Unfortunately, that mother died and was presented on the national forum. I'm yet to forgive that facility. Yeah, so please have your, we'll talk about the kit later, but 5 grams or 50% with lignocaine 1 ml on alternate buttocks every 4 hours for 24 hours after delivery or the last convulsion, whichever occurred last. So that is to say, we do not have a maximum dose of magnesium sulfate. I've been to facilities where people say, we have given the 6 doses and completed. You can only complete maintenance dose of magnesium sulfate if you've given it 24 hours after the delivery. The 24-hour count starts after delivery of the baby, or the last convulsion, whichever occurred last. Okay? And in case you've given the loading dose and the patient fits before the next maintenance dose, we give what we call a rescue dose, which is half of the 4 grams given IV. So you give 2 grams of 20% magnesium sulfate. That is a rescue dose. Then after that rescue dose, you'll give your next maintenance dose as scheduled. So if you gave the loading dose at 2 p.m., and you're supposed to give your maintenance dose at 6 p.m., but the patient fits at 3 p.m., you'll give that 2 grams of 20% and give the actual maintenance dose at 6 p.m. as scheduled. So you do not prolong the time or half the time, okay? And then you do clinical assessment for toxicity. Now, toxicity is done every 1 to 2 hours for magnesium sulfate, and my colleague will talk about it, how to assess for toxicity. But you can only give your maintenance dose if you have the patellar reflex is present. So that's to say, the first sign to show toxicity is absent patellar reflex. And toxicity, these signs come in order. The higher the amount of magnesium in blood, the more signs you get. So we start with absent patellar reflex. By the time you reach respiratory rate depression, you really have very high levels of magnesium sulfate in the system. So don't wait to assess at 4 hours, because we know the half-life of magnesium sulfate actually peaks within an hour, then starts dropping. So that's why we do every 1 to 2 hours, assessing what? The level of toxicity. Someone is asking, we shall answer questions about AKI, but if you, in case the patient have acute kidney injury, and we'll talk about the criteria, whether you use right or off criteria, is you have the maintenance dose. Thank you for bringing that up also. If you have acute kidney injury based on your creatinine levels more than 1.1, the maintenance dose should be half, but you continue giving. Okay, next slide. All right, so that was goal 1, we control or manage convulsions. Goal number 2 is to treat hypertension. So hypertension, we may have 2 categories: the non-severe hypertension, where our systolic blood pressure is greater than or equal to 140, but less than 160. So we are between 140 and 159. And then the diastolic is more than 90, but less than 110. So we are between 90 to 109. That is non-severe hypertension. So what are the drugs? We strictly use oral medication. We do not give sublingual nifedipine. That's point 1. We use oral medications to control this blood pressure. So we start, you can do labetalol, you can do nifedipine, you can do methyl dopa, you can do a combination of these. Now, if your patient presented with headache as one of the symptoms, the severe symptoms, you do not want to start with nifedipine, because the biggest side effect of nifedipine is actually headache. So you will not be able to tell whether this headache that the patient continues to have is due to nifedipine or actually due to the high blood pressure. So you're better off starting with methyl dopa or oral labetalol, which are very available. So the decision to do 1 drug or 2 depends on your blood pressure and the control. Nifedipine, we start 20 milligrams once a day. You can observe. Or you can do methyl dopa 250, or you can combine methyl dopa and nifedipine. The highest dose of methyl dopa you can give is 750 milligrams 3 times a day. But you can start with 250 3 times a day. You monitor the blood pressure. It's not improving. You do 500 3 times a day combined with nifedipine, and maximum is 750. So it is based on the reading, the subsequent readings you give. And again, taking into account, you do not want to drop this blood pressure too fast because you cause ischemic stroke in the patient. So the blood pressure should be lowered gradually over days to hours. It's very interesting when you see after 30 minutes, your blood pressure has dropped from 160 to 110 and you're excited. You've actually caused the patient more harm than good. So this blood pressure should be lowered gradually over hours to days. And our target blood pressure is usually to keep the systolic between 130 to 139 and the diastolic between 80 to 89. But this target is not to be achieved in one day or in a few hours. It is gradually. Nifedipine causes crashes blood pressure very fast. So you do not, given sublingually, because it's associated with hypertension, like someone has said there, crashes the blood pressure and you're sending the patient to ischemic stroke. Next. Okay, so that was non-severe hypertension. Now we have the severe hypertension, where the blood pressure, the systolic is above 160 and the diastolic is above 110. It's not 100, but 110. And the question here is you do not need both to be above. So it can be just the systolic, which is 160, and diastolic is 100, and let's say, or 100. Or the systolic is 140, but diastolic is 130. That is severe hypertension. So what do? We use hydralazine or labetalol. There is also immediate release nifedipine, but which is not in our system, so I will not talk about it. We don't have it in any of our facilities apart from some few PNFPs. So our first line choices are hydralazine or labetalol. Hydralazine given 5 milligrams IV slowly. I don't want to hear the word bolus because it's associated with fast administration. So 5 milligrams IV slowly over 10 to 15 minutes, and then you repeat every 30 minutes until the blood pressure is in the non-severe category for either systolic or diastolic, depending on what was your indication. The maximum dose of hydralazine you can give in 24 hours is that one vial, which is 20 milligrams. So that means every 30 minutes you're going to repeat the 5 milligrams. And we'll go through how to mix hydralazine because it comes as 20 milligrams of 1 ml in one vial, and most times you end up crashing the blood pressure. The caution here is to dilute it as maximum as possible and give it slowly. There's no one who can convince me they can give 1 ml of hydralazine in 10 to 15 minutes. So we shall look at the mixing. Once the blood pressure is reduced, then you continue with the orals. Now, the thing is, do not give hydralazine and then wait to start the orals later, because we know hydralazine and labetalol have very short half-life. Hydralazine, we say 30 minutes. Labetalol is even shorter, 20 minutes. So if you wait to start the orals the following day, you're going to have a time period within which there's no drug actually in the system to control the blood pressure. So we always encourage that to start concurrently. Once you started the hydralazine, start the orals as well. Most times you'll need about 2 doses of either hydralazine or labetalol before the orals have peaked. We know that it takes about an hour for nifedipine to actually peak in the system to reach the efficacy level. So that means you need at least 2 doses of hydralazine. So we start them concurrently. We've had people say the blood pressure is uncontrolled, yet actually the patient does not have any drugs in the system to control the blood pressure because of delays in starting the orals. The second drug is labetalol, given as 20 milligrams, slow IV over 2 minutes, and you double the dose every 20 minutes until your blood pressure is in the non-severe category. So if you started with hydralazine, you achieve maximum dose, it's still not controlling the blood pressure, you can switch to labetalol, and the reverse is also true. If you're in a BMOC site, just to give your loading dose of magnesium sulfate, If you don't have IV hydralazine, you don't have labetalol, please give oral nifedipine or oral methyl dopa and refer the mother. It does not matter how high the blood pressure is. We emphasize with the drug orally and then refer to the simoxide. Okay, so in the intrapartum period, again, just to emphasize, pre-eclampsia or eclampsia is not an indication for cesarean section. So you have to determine at what point you think your mother will deliver, okay? So if a mother comes with eclampsia, she's 7 centimeters, we do not rush to theater to deliver, to do cesarean section. That's a mother, you can rupture membranes, allow them progress, and they deliver vaginally. So it is vaginal route is preferred unless you have an obstetric indication for the C-section. For instance, if a mother comes fitting and you do a vaginal exam, she's not in labor, you know if you induce, she's not going to deliver the next 12 hours, that's a mother you take to theater. So that's just to say, pre-eclampsia without severe features, initiate delivery within 24 hours. Then eclampsia, 12 hours. So for a mother in labor with eclampsia, that one can progress and actually deliver, unless you have another reason for doing the cesarean section. So continuous maternal fetal monitoring is indicated, and then because of the risk of pulmonary edema, we restrict fluid intake to 8 ml per hour. That means that one bottle of normal saline should at least take you 4 hours in a mother with preeclampsia, just so that you don't have fluid overload. Next. So we need close monitoring of the patients after delivery for at least 3 days. Please do not disturb the mother with preeclampsia before the 3rd day, irrespective of the route of delivery. Even if she had a vaginal delivery, at least monitor the blood pressure for at least 3 days before you discharge. But some patients, of course, will require a longer stay based on their blood pressure. We repeat laboratory tests until they are 2 consecutive normal, but sometimes the results take long, so until they are tending, they may not be normal, but they should be on a downward trend towards the normal. And then, like we said, we complete magnesium sulfate only after delivery, and that is 24 hours after the delivery. And then you keep adjusting your antihypertensive drugs depending on the blood pressure. We do not wean off patients abruptly. We taper down doses of antihypertensives. If the patient was on 500, maybe you want to come to 250 for another 2-3 days. Then again, you wean off one drug, maintain one until you take them completely off. So tapering of antihypertensives, blood pressure should still be more continued until you are able to stop. Unless the mother is unstable, they can be discharged on day 5 for postoperative mothers. You follow up the patient. This is goal 4, which is the postpartum follow-up. Sorry about that. We review the patient in our clinics on 1st week, 2nd week, 6 weeks, and 12 weeks. And why 12 weeks? Because we know that if the hypertension persists after 12 weeks, we have changed, we are no longer preeclampsia. This is the patient with chronic hypertension, and you want to hand over the care to a physician to start them on the other antihypertensive drugs that are not used in pregnancy. Just to emphasize, we only use labetalol, hydralazine, metazopam, nifedipine, which are safe for pregnancy. But we know we have better other drugs that can control blood pressure, but they are not recommended. So you want to transfer this mother to a physician to start them, and then they are diagnosed as patients with chronic. Okay, some mothers may require more frequent follow-up, so don't restrict yourself to the 1 to 6 weeks, because you realize between 2 and 6 weeks, mothers may develop complications. So it is really on a case-by-case basis. And for each visit, you want to repeat your lab and also take your blood pressure. And some patients may require extra workup like ECG echo, but that is dependent on the patient to have at hand. Okay. So patients who have had preeclampsia have long-term complications. Many survivors have these long-term complications. One is you're at risk of a recurrent preeclampsia and the subsequent pregnancy. preterm deliveries. So we have what we call the immediate complications in the pregnancy and then the long term. The immediate ones are really while you're still pregnant, you have risk of growth restriction, preterm delivery, abruption, stillbirth, and also all those what we call the great obstetric syndrome. But in the long term, you're at risk of developing chronic hypertension. So as you discharge these mothers, you want all them to keep monitoring their blood pressure, but also live a healthy lifestyle, exercising and all that diet that we talk about. The risk of chronic kidney disease, especially those who have had acute kidney injury as one of the complications. The risk of getting diabetes, and interestingly, depression, anxiety, and all those mental health disorders. So what do we do? As we follow them up, we want to do regular screening, BP monitoring, monitor the weight, and encourage exercise. And also, for the subsequent pregnancy, we want to do preconception care. And we shall talk about this in the prevention. Next. Yes. So who remembers what goal 5 was? Okay, so our goal 5 was on prevention and prevention of risks and recurrence. And I've not put a slide to this because my colleague already talked about the risks, the high risk and moderate risk factors. So in the prevention of risks, we talk about the guideline has approved administration of low dose aspirin, which is 150 milligrams of aspirin. The normal aspirin we have in our setting, the one we use for arthritis and all these things, just to give a low dose of 150. In the initial guideline, it was 75 milligrams. That was too low, lower than all the international standards. So we increased it to 150 milligrams. We said give at night, but I know also many of us have been candidates of pre-eclampsia and we do night duties and some other activities. So we prefer to say given at rest. If my night is daytime and we sleep during day, please give at rest because it has been proven to work best when the patient is at rest. And we start this at 11 weeks, but before 16 weeks. We start there. So if you identify one patient with one high risk factor Dr. Lozire talked about, multiple pregnancy, which our patient was a candidate for. Patient who had previous history of preeclampsia, IVF with a recent change in partner, and all those risk factors, we give 150 milligrams daily up to 36 weeks or 24 hours before a planned delivery. But you should start at 11 weeks, but before 16 weeks for obvious reasons of the pathophysiology, where we know that the damage is done during placental development. So that means if the patient comes after 16 weeks, then it is not beneficial to start aspirin. We need to start it early. So that's why we need to encourage mothers to come early for antenatal care. The other drug that has been proven, and people are using it a lot more than even aspirin in the risk reduction and prevention is calcium. This has been adopted by WHO. However, WHO puts a connotation that it should be given in dietary deficient areas. Now, for us in Uganda, we don't know whether matoke is deficient in calcium. That's for another day. Or my fresh cassava, Mogalovo from Lano sub-region is deficient. So because of our variety in diet, we do not have data that shows dietary deficient. But in private practice, people are using it a lot, and the benefits actually outweigh the risk, if any, because we know calcium is very beneficial to the mother, even in the lactating period. So we give calcium 300 milligrams also once a day for risk reduction, but it's not in the guideline because of the issue of dietary deficient areas. But for aspirin, they are 150 milligrams once a day from 16 before 16 weeks, but from 11 weeks. And when you start to continue up to 36. So that is it about my presentation. Thank you very much for listening.
Wow, thank you so much, Dr. Jackie, for that wonderful presentation. And every time you walk us through this presentation, there's actually something that I learned every other single time. Please keep the questions coming. And let us address the questions in the Q&A. Please don't put the questions in the chat. Let them be in the Q&A so that the expert can keep answering those questions. So at this point, I want to invite Anita, our midwife, to take us through the monitoring of a patient with pre-eclampsia. And she's equally going to demonstrate to us how do we mix magnesium sulfate and how do we give the magnesium sulfate anyway? And also how do we communicate to the mother as we are going to give magnesium sulfate? Over to you, Anita.
Thank you so much, the moderator. And my name is Anita Sasira. I'm a midwife. I'm going to talk about, Dr. Jackie has made my work so easy that I'm going to talk about a few things, but with emphasis on some. So we are going to have my presentation shared. And then we are going to have a demonstration of what we need.
So as Anita is waiting to have her presentation loaded, I know she's going to emphasize on the issue of emergency readiness and preparedness for management of preeclampsia, eclampsia. So for our dear midwives who are there listening in, this is your time to listen in so critically so that we have our PET kits ready to save the lives of our mothers. I think it's ready. Over to you, Anita.
Thank you so much, Adija. So I'm going to take you through the presentation that I have, which is very short. Then we can do the demonstration and we see what we need and how do we do the mixing and the monitoring of magnesium sulfate. So we've already talked about the loading dose. Dr. Jackie has already taken us through the loading dose. We give a loading dose of 14 grams, whereby we have 10 grams or 50% intramuscularly, and we give 5 grams on each buttock. Please don't forget to add 2%, 1 ml of 2% lignocaine. It's very painful, and we need to always add lignocaine to this drug. Then we also have the 4 grams of 20%, which is IV, very slowly given. And we are going to see how we mix the 4 grams to get 20%. Then we also have a maintenance dose, which we've already seen, which we've already talked about. And most importantly is always check for toxicity before we give every other dose of magnesium sulfate. Most of the times we just say it's written and we just go and give. Please always check for toxicity before you give another dose of magnesium sulfate. Next. So how do we make 20% of magnesium sulfate? It depends on what you have, the syringes that you have at your facility. Sometimes we fail to give these drugs because we don't have bigger syringes. Someone will say, I failed, I had only a 5 ml syringe, but we have all that catered for. And when you're using a 20 ml syringe, you're going to put 8 mils, which is the 4 gram or 50% in a 20 ml syringe, and then you add 12 mils of water for injection. When you're using a 10 ml syringe, use 2 syringes of 10 mils, and then you put 4 mils, which is 2 grams or 50% of magnesium sulfate, and then you add 6 mils of water for injection in each of your 2 syringes. When you're using a 5 ml syringe, get 4 syringes of 5 mils, and in each of them, put 2 mils of magnesium sulfate, which is 1 gram or 50%, and then add 3 mils of water for injection in each of your 4 syringes. We are going to demonstrate that, how we are to mix that. So when we are monitoring, as I've already said, that before giving any other dose of magnesium sulfate, make sure that you check for toxicity. Please make sure that you do this. You check for the respiratory rate every hour. Sometimes we fail to monitor. We fail to notice that there is toxicity because we don't monitor. if you've been attending our MPDSR meetings, one of the most leading causes of these deaths is because we don't monitor our mothers. Let it be PET, PPH, but mostly let's always monitor our mothers. When we monitor, you're able to tell what's happening. When you're monitoring, you're able to notice that something is not right with your mother. So one, you're going to look at this respiratory rate hourly. In our guide, in our books, we have 16 breaths per minute. And if you have that is below 16, it means that we have a respiratory distress. Dr. Jackie talked about 12, but we don't want to reach 12. If you have a respiratory rate that is below 16, please note that you may end up in respiratory distress. Then we talked about the deep tendon reflexes. We are also supposed to monitor them 1 to 2 hours. Urine output every hour, and if you see that in your catheter, you don't have 30 mils within an hour, you have that as an indicator that you may end up into magnesium toxicity. Then we also need to see the level of consciousness for our mothers. You check their mental status and alertness. We are also supposed to have oxygen concentration monitored. And then in advanced settings, we can do laboratory monitoring of the magnesium. We can do a serum magnesium, which the normal is 2 to 3.5 millimoles per liter. And then we can also, if you are able, you can do an ECG for especially patients where you can suspect arrhythmias, you can do for them ECG. And if there is toxicity present, if you notice that you have any of the above, you can stop magnesium sulfate, and you can either, depending on the severity of toxicity, you can reduce the doses, or you can stop magnesium sulfate and you look at maybe using something else that can help us control the convulsions. What are the signs of toxicity? In mild toxicity, we shall have flushing, we shall have hypotension. Like Dr. Jack has already said, that you can't control this blood pressure. In 1 hour, you're in 160, and within 1 hour, you're having 1 or 110, or you're having maybe 120. It's a process. So if you notice there is hypotension, please know that that may be a sign of toxicity. If there is nausea, if there is sweating, if there is vomiting. And if in moderate toxicity, you're going to have a respiratory distress, and you will have 12 breaths per minute. You will have orgulia. We talked about that, where we have less than 30 mils of urine in your urine bag per hour. Then you will not have the deep tendon reflexes. Then in severe toxicity, we shall have bradycardia, we shall have severe hypotension, we shall have respiratory paralysis, we shall have arrhythmias, and in worst case scenarios, we have a cardiac arrest. So what are the interventions if you notice there is toxicity? One, you're going to give calcium gluconate, and this is 1 gram. It's an ampule of 10 mils, and it's given for over 10 minutes. Please let's not rush the drugs when we are giving our mothers drugs. Let's give them according to the time that is indicated for them to give. Then you continue monitoring, you monitor their respiration, you monitor their oxygen saturation, and then you monitor their urine output. Then, as I said, we also do an ECG if we can. Then, without also forgetting the nursing care that you're supposed to give this mother. Make sure that you communicate with them, make sure that you turn them, and make sure that you always, if the mother is not able to talk to you, please inform the attendants. Some of the things that we do, we just do because, yes, I understand it's an emergency, but please communicate to these patients, communicate to these attendants. They have a right to know what is happening, and it also helps them to reduce their anxieties when we talk to them. So that is how short my presentation was, but mostly we are going to look at how to prepare to be ready. I have this kit. This is how we prepare. We don't want you to start running looking for magnesium sulfate from somewhere else. Then it's under here and low. Then you're looking for a syringe that is nowhere. So you have this kit that is prepared for you. And there are things that I don't know if we can zoom into this or I can read. So there are things that are needed in this kit that you must have when you're preparing for any emergencies. You must have, and most importantly, always check on your list to make sure that you have everything in this kit that is written on this list. I'm going to read one by one, but it's very important that you also keep this list as you're giving your report in the morning or in the night. Someone is able to tell that whatever is on this list, you have it, because they are very key when we are preparing for emergencies. So our list has magnesium sulfate. You can at least have 10 ampoules of 5 grams. Then we have syringes, 20 mils. Make sure I have 2 syringes of 20 mils. Make sure I have 10 syringes. I'm going to start to show you these things as we talk about them. So these are my 10 mil syringes. So I have my 10 mil syringes here. Then I have my 5 mil syringes here. I have my 20 mil syringes here. So you put 6 10 mil syringes in this kit. You put 10 5 mil syringes. Then I have extras. But you're supposed to have at least 2 20 mil syringes in this kit. You're supposed to have 2 urinary catheters in this kit. You're supposed to have a urinary bag. Then we need gloves in this kit. You can have disposable gloves and surgical gloves in our kit. Then we need swabs in the kit. We also need magnesium sulfate. We need calcium gluconate. We need hydralazine in our kit. We need methyl dopa. We need labetalol. We need nifedipine in our kit. We need lignocaine. We are saying make sure that you give the drug with 2% of lignocaine, 1 ml when you're giving the IM. So you need the lignocaine. You need strapping. You don't want to keep running to look for some of these things. Then you need cannulas. You're supposed to have all sizes in this kit, but in some facilities you may not have. So I have a gray cannula, I have a green cannula, I have a pink cannula, and I have a blue cannula. So we need all these sizes in our kit. I have at least 2 of them, that in case you're using one, if it's maybe you put it in a tissue, you get another one, you're able to use them. Then we need water for injection, which is also there. Then we need batch trainers. When you receive these mothers, we are going to take off samples. So we need batch trainers. You don't need first to run to the lab to look for batch trainers. So this is what we have in our kit. And don't forget that you need this list. So sometimes we are in facilities and we don't hand over. So it's very, very important that every day you check on this kit to make sure that you have all these things in your kit, because at the end of the day, when we have these emergencies, we want you to concentrate on doing what you're supposed to do other than running around to look for these things. So the next thing we are going to look at is how to mix magnesium sulfate in the way that we talked about. So if this magnesium sulfate is 50%, 100 magnesium sulfate, which is 5 grams, is 50%. So it's very important that before you give any drugs, I've been to facilities, and because they put the kit there, they never check the expiry drugs of these. they never check the expiry dates of these drugs. So it's very, very important that we don't cause more harm to our patients. We check for expiry dates before giving any drug. Please make sure that you check for the expiry date. And this will happen if you're handing over every day, and if you're able to check that what I need in my kit is ready. So this is magnesium sulfate. It's written on magnesium sulfate 50%, and then its expiry date is July 2020.
Salon, a quite big
This is
one.
what I have, and I'm going to show you how to mix 4%, 4 grams of 20% using a 20 ml syringe. So I will have my water for injection and this one. So this is 5 grams, but I need to get 4 grams out of it and make 20% of the 4 grams.
Need help? Or it's called for help.
Emergency.
So we have our ampoule here, which has 5 grams or 50%. So Dr. Jack is going to help me draw 4 grams or 50%. Then we make it 20%. So Dr. Jack, you're going to draw for me 8 mils. I draw only. Let me draw. So I have my 8 mils of 50%, but I want to make it 20%. And remember, we said 8 mils is 4 grams. So I will add, I'm going to add water for injection 12 mils, make it 20%.
Hold on. So for those asking, how do we come to 12 mils of water and 8 mils of magnesium sulfate? Please go back to your senior 4, where you did M1, C1, V1 is equal to C2, V2. So we're looking for concentration 2, which is 20%. What volume should we add? We're not going to go through this, but this was already done for us. So 8 mils of magnesium sulfate, which is from this vial, which is 10 mil. You add 12 mils of water for injection to get your 20% concentration. But that's the formula. So I have 20 mils, but this is 4 grams of 20%. So with all these other syringes, this is what you're supposed to do. You're supposed, like I said, when you have a 10 mil syringe, please, to make it easier for us not to go back into the calculation, just put it in your head that if I have only 10 mil syringes in my facility, what am I supposed to do? Get 2 mils of get 4 mils of magnesium sulfate 50%, put it in one syringe, get another 4 mils of magnesium sulfate, which is also 2 grams of 50%, and add 6 mils to each. If I have a 5 mil syringe, just pick 1 mil of magnesium sulfate, 2 mils of magnesium sulfate, 50%, and add 3 mils of water for injection and have 4 of those. Then when you're getting magnesium sulfate,
please, 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 if you can't stand, get a chair and sit beside the patient. This drug is very, the moment you start giving, if you give it so fast, the patient will tell you they are feeling heat all over their bodies. If you've ever given magnesium sulfate, some people will tell these mothers, get up and have a cold water, but we don't have evidence about that. So take about 20 to 30 minutes to give this drug. Give it as slow as possible, because at the end of the day, you don't want the patient to feel so uncomfortable, and then you don't want to cause other issues to this patient. So if you've ever given magnesium sulfate, if you've ever talked to a mother who has received magnesium sulfate, please, please sit beside this patient and give the dose the way it's supposed to be given. Some of us will say, but we are very busy. At a national referral, in a regional referral, there is a mother pushing, there is, please. You can even say, I'm going to give slowly 1 meal. I first want, but I want you to sit beside this patient. And I don't want to rush you to rush giving this drug. The same with the IM. Please add lignocaine to it. It's very, very important that we add lignocaine to it. And when you're giving these drugs, explain to them the side effects. The mother will start telling you, I'm feeling it all over my body. It's because you didn't explain to her. Just talk to the patient, tell her, I'm going to give you this drug, but this is what we expect. You may feel a lot of it, you may start sweating, but as I'm giving it slowly, in case you feel so bad, please let me know. Tell me how you're feeling, tell me what you're feeling. It's going to be very, very helpful, and your mother will not say, the other child gave me the drug so fast, it almost killed me. I got a lot of it inside. So that is what I was to talk about, mixing magnesium sulfate, and we can always refer to the presentation that we are going to share to look at how many meals am I supposed to give. Thank you very much.
Yes, please.
Thank you. Just to emphasize that if you don't have 20 ml syringes and 10 ml syringes, you can still give your loading dose. You will need, and that is why we have this number of items in our kits. If you only have 5 ml syringes, that means you will need 8 5 ml syringes to give your loading dose of magnesium sulfate. The IV alone will use 4 syringes. The IM will also use 4 syringes. So you will need 8. It's just knowing how much do I withdraw, how much water to add. But as we conclude, because of time, I want to talk about hydralazine. We've had so many cases this year of mothers dying because we gave hydralazine too fast. So hydralazine, the vial here, there's both powder and liquid, but commonly I think we have the liquid. It comes at 20 milligrams per meal. So in this one vial, we have 20 milligrams. And yet we are saying give 5 milligrams. So in this vial, we encourage that you use a 20 ml syringe. But if you don't have, then you can, the smallest you can use is a 10 ml syringe. But we encourage that you use a 20 ml syringe. That's why our kit list is having all these numbers of syringes. Why should you have 20 ml syringes, 2 of them in the kit? Because you're going to give loading dose and you're going to give hydralazine. So if you're using the 20 ml syringe, this is 1 ml, 20 milligrams. So withdraw this 1 ml into your 20 ml syringe, and then you add 19 mils of water for injection. So that means 1 ml will be equal to 1 milligram. So you'll give 5 mils, which is 5 milligrams, slowly over 10 to 15 minutes. The moment you push hydralazine too fast, you're going to crash the blood pressure. Patient is taken for for surgery, spinal anesthesia also lowers blood pressure. The next thing we know is you are not coming out of stable. We've had these cases presented, and this is why we are emphasizing. If you have a 10 ml syringe, you're going to withdraw your 1 ml, which has 20 milligrams. Then you add 9 mils of water for injection. So you will have 20 milligrams in 10 mils. So that means each meal has 2 milligrams. So you'll give 2.5 mils to give your 5 milligrams. Please do not give it too fast. For centers that have infusion pumps for both magnesium sulfate, and I mean syringe pumps, not those other, the syringe pumps, you can actually time this. You touch it to the syringe pump and then you time, and it gives exactly as you have described. Thank you. We are time back, so we'll not go through all the practical sessions.
Thank you very much. Maybe one last thing is sometimes we send our attendants to go and buy the things. Make sure that if you use anything from this kit, as you're sending the attendant to buy, when they come back, please reflect. We've had Dr. Mgai tell us that you used your PHC money to buy some of these things. Please do. That money is there. You can buy a few things and these attendants can always buy and you restock. Thank you very much.
Thank you so much, Anita and Dr. Jackie, for that wonderful practical session. Maybe before I forget, Anita, I heard you were emphasizing monitoring of toxicity for magnesium sulfate. Does that mean that we need to have a patella hammer in the PET kit?
Yes, you can have it, and in our facilities, if you can access it, please have one. I didn't come with one today, but you can always look out and monitor using patella hammers to check for deep tendon reflexes.
All right. So thank you so much. Colleagues, we are diving into the session for the questions. I know we are time, but I think I'm going to give an opportunity to only 3. Some of the questions have been answered in the Q&A. So 3 burning questions. You can put up your hand, please. I haven't seen any hands. Maybe I can pick from the chat. There's a question that I saw. So their hands, eh? Okay. Simon? Yes, Simon, please go ahead and ask. Are you able to unmute?
Yeah, thank you for the presentation. My question is, maybe I start by my name. I'm Abalo Jacinda, the head nurse, Yumbi Regional Referral Hospital. My question is only one and simple. Regardless of any gestational age, a mother is breastfeeding. Can't it be handled as an emergency where cesarean section is required?
Okay, the experts
Because
have
according to
captured.
the statement, it is optional.
Okay, thank you so much,
As
sister. The
emergency
experts.
cesarean section be
Okay, thank you, sister. Yes, thank you so much. The experts are going to answer. Let us hear from Ambrose.
Yes, please. Good afternoon, everybody. My name is Odonkara Ambrose, and I'm a clinical officer. Yeah, my question is about the postpartum occurrence of the eclampsia. I don't know if I would like to ask if there is any occurrence with peripartum cardiomyopathy, because of recent it has also been noted that the peripartum cardiomyopathies are also a leading cause of they say they are associated with eclampsia because they diagnose it like postpartum period 1 month. So I don't know if it is also if it can contribute to this postpartum eclampsia. Is what I want to know with peripartum cardiomyopathy. Yes.
Okay, thank you so much, Ambrose. Your question is captured. I think we have, wow, the hands are getting many. Barbara, you can ask your question, please.
Thank you very much, Hadija, for the moderation, and to the presenters. It was really so good. Mine is just a concern about midwives in the lower facilities. Most times you find that they are challenged. There are no BPs. Sometimes the BPs are there, but there are no dry cells to run these BPs. How are we going to really support them to really see that we have functional BPs? And then these mothers with the PET that have been diagnosed in antenatal, the biggest challenge I've seen here where I am is you find that the mother has been referred to a CMOC site to attend her antenatal there, but the CMOC site is like 40 kilometers. She will tell you, I don't even have transport to just go even for one visit. How are we going to support these mothers in hard to reach areas to really attend their visits at a CIMOC facility?
Thank you so much, Barbara, for that wonderful question and concern. So we are picking one more?
Yeah.
Just one more. Dr. Baifa, over to you. There too.
Thank you
Okay.
very much, Aditi.
Yes.
And team. Thank you, the expert, Jackie and team. I would like to hear from Dr. Jackie and team, how do you deal with mothers with pre-eclampsia with severe features who receive termination of pregnancy, and sometimes they have very genuine reasons why they want their baby. Oftentimes it's a precious baby. How do you go about these mothers? I have one that insisted she does not want termination and she signed. How do you go about this over that end? Thank you.
Thank you so much, Dr. Baifa, for that question. And I think we have the last hand. Arik, 1 minute, please. Arik, you're there?
Okay, thank you. Thank you, team, for the presentation. I just want to know the significance of 4 hours apart as a criteria for diagnosing preeclampsia. I mean, as one of the criteria for hypertensive disorders. Does that mean that I need to wait if I find a woman has high blood pressure? Should I wait for 4 hours before I initiate antihypertensive? What is the significance of that criteria? Thank you.
Thank you, Eric, for that question. So now I hand it over to the experts. I don't know who wants to go first.
Okay, so thank you so much for the question. And just before I forget, we have another session on Tuesday at 7 p.m. And the session on Tuesday at 7 p.m. is really very academic advances in preeclampsia. So for those who are interested in things like at molecular level, you're welcome to join us. The flyer is going to be out. It's for majorly AWUGO members, but everyone is welcome to join. So I'll start with the first question, which was asked by my colleague from Yombe, I forget the name. Regardless of gestational age, why don't we treat a mother who is having eclampsia as an emergency and do a cesarean section? Now we are going to tell you that the C-section is not going to be the one to save the mother. You need to first control the blood pressure, but also stabilize and ensure she's not fitting, and then you decide. But like we just emphasized that eclampsia is not really an indication for C-section, especially if the mother is already in labor. We've had mothers push even in ICU when they are unconscious. So you want to optimize her parameters, because we know also cesarean section comes with its own complications, even in the postoperative period. So control the fits, control the hypertension, have proper review of the patient, and then you decide whether she can deliver within the next 12 hours or the best is to have a C-section. But the end goal should not be having a cesarean section. The second question was about peripartum myopathy and the preeclampsia. It's quite common. I agree with you. And I think one of our colleagues is actually doing this study in Kawempe, Dr. Broma, looking at development of heart-related conditions in patients who have had preeclampsia. And this is one of the commonest findings. And that is why in the follow-up, you see, we are recommending that these patients have ECG echo done at around 6 and 12 weeks. Because it's a common finding, they actually go hand in hand. And most patients who have had preeclampsia are at risk of getting cardiac disease in the future. So it's a very common finding and observation. Concerns about blood pressure. Now, unfortunately, I don't participate in the national budget. But for those of you who have listened to the budget review, you realize that out of the 71 trillion, I don't remember the figure, only about 2-point-something billion has been given to health. So that means we're still going to have all these challenges and shortages. And we really can't blame Ministry of Health for not having all these supplies. But also we've been to facilities where clearly the BP machine is there and the midwife does not take blood pressure. Case in point is a case currently on social media and some of the LNMS platforms. The mother who died in one of our regional referrals, who attended antenatal 5 times and blood pressure was not taken, only to come with PET severe features and died in ICU in one of our regional referrals. So it really goes back to us as health workers. Ministry has given us a go ahead to use PHC to buy some of these things because RPF has been streamlined into PHC as well. We are also working as PET subcommittee to see if we can have partners who can buy for us BP machines that are chargeable. And this was one of the reasons for our run in Mbale. We thank the teams, and I must thank Yumbe. I think apart from Mbale region, West Nile again was the biggest support for buying the best steward buying these BP machines. And we've been able to raise some good money, but it's only for machines in Elgon region. So the BP machines we're buying in Elgon region are really the ones that are rechargeable. They have 2 options. You can do buy cells, but also you can charge them with a normal phone charger, these pin chargers. So that's really what we're looking forward to, but we're also calling on partners to help us. We're trying to work with UHA to see if we can procure for their areas which they support. But yes, it's a concern that we acknowledge. How do you deal with a mother who has pre-eclampsia severe features and has signed and does not want termination of pregnancy? I myself have faced this in Kawempe. How do you deal with it? I'm not going to say there's a correct answer, but at least what we know is this mother, first of all, has to be admitted and then has to agree to do the daily labs and daily scan. And you will keep noticing worsening symptoms. We still try to encourage them to terminate. And now the decision on whether if she has signed, unfortunately, if she has signed that you should not terminate, then you cannot. But you can seek opinion of at least 2 or 3 clinicians and agree. But there's really no, it's a gray area, Dr. Baifa. I've had this challenge with a Dinka, and unfortunately, we lost the mother and the baby in Kawempe because clearly they also signed and said, thou shalt not terminate my pregnancy. I mean, the guy had paid 100 cows, according to him. So maybe Dr. Ondozire will add to that, but it's a really tricky area. And much as the guideline says terminate, it's not a clear-cut case of termination if the mother says no, or the relatives. Someone asked the significance of 4 hours for diagnosis. So one is that we know if you've had intense activity, you walked up the stairs and been exercising and all that, your blood pressure will always go up a little. So when the mother has just arrived and you take the blood pressure and you find it up, but it's non-severe, we want you we want the mother to sit, relax, calm, first be calm before you take the next blood pressure. But that is only if it is in the non-severe category. However, once the blood pressure is in the severe range, systolic above 160 or diastolic above 110, we actually recommend you repeat within 15 minutes. You repeat the blood pressure within 15 minutes. So the 4-hour luxury is only for those with blood pressure. You find it's 140 over 85, and you're not sure if it's because she has climbed the stairs. That's where you have the luxury of waiting for 4 hours. It's a very good question, and I think I'll bring this to the subcommittee. Why 4 hours and not 2 hours? That is something to be discussed, I think, even as we talk about the advances on Monday. Thank you. Over to you.
Thank you very much, Dr. Jackie. That's been very insightful. Dr. Baifa, it's one of those dilemmas that we face as clinicians. You have a diagnosis, you have the treatment, but the patient refuses the treatment, probably because they have their cultural issues, or they have family that telling them ABCD, or maybe they don't think this is a problem. So as Dr. Jackie said, do what we call a family conference, because most of these patients that we have, they have family behind them who actually making decisions for them. So have a family conference and go step by step, complications and what is likely to happen, including death. And we have what we call autonomy. The patient has a right to make a decision about their health, about their life. So if the mother decides that no, do not terminate, I've understood what is likely to happen to me, have sign, and then continue doing your best, monitor and give treatment, and then see outcomes. I think Prof. Nachini one day gave us a story of a patient who came with pre-eclampsia with severe features at around 20 weeks. And then, of course, everybody said, let's terminate. Her liver functions were so high, everything was bad. She said no, she ran away. She came back at term and delivered a live baby. So, so some of those things might be very difficult for us to determine what is likely to happen, but we use evidence, we use science. So explain the evidence and let the patient or and the relatives make a decision, because usually those are the people who are giving the advice. Then the 4 hours of the blood pressure, normally when we take a blood pressure, we need to give the patient time. There's what we call a white coat syndrome. When a patient comes to hospital, the memories probably of some illness they had, or the likelihood of getting a diagnosis from a hospital raises their blood pressure because of anxiety. So you need to exclude all that. But in an event that you take a blood pressure that is 160 and diastolic 110, kindly start treatment. Do not wait do not wait for 4 hours. Otherwise, the patient will convulse, and then you have other issues come up. Yes, I don't know if there's a question you haven't answered, but
Not really. Actually, which one? We are running out of time. Which particular one?
There is one where Barbara asked if these patients are sent from BMOC facilities and are not going to the CMOC facility. So I would think sometimes we don't have control over some events, and what we need to do is to basically document. If your plan was to refer, document properly and why you're referring, and more so explain to these mothers why you're referring them. They may not be having the money, but their life should not be at risk. They should also try to find means. And sometimes we can go with these patients, with these mothers. But if you have an ambulance, if there is means, please take them to this CMOC facility. Make sure that you've gone with them, you've handed them over, and the CMOC facility will also start from there. But sometimes you're unable to, be able to monitor them, and sometimes they don't even come back. They come back when they are very sick. So document and also escort them where possible to the CMOC facilities.
Oh, thank you so much, Anita. And I think also this brings in the component of emergency preparedness for our mothers. That for as long as we are preparing our facilities, but I think also we need to prepare the mothers, have some emergency little money, so that in case you're referred from a BMOC facility to a CMOC facility, ambulance has no fuel, you have where to start from. So colleagues, we are coming to the end of our session. It's been really a very live session, interactive, and a lot of learning happening here. So we are going into the pre-tests. Please don't go away. The questions are on your screen. Sorry, post-test. Yes. People finished already. Questions in the general assessment. It shouldn't really take us so long. And then I think as they answer, we can have the last words from our experts. Yes? Yes. Starting from, I started from this side, so let me start from this side. Yeah, Anita, your last words to our participants.
Thank you so much. Everyone who has been on this webinar. We appreciate you putting in time to be here, and we can do this together. We can reduce maternal mortality, And to our midwives out there, please do what you need to do. If mothers are attending antenatal, make sure you take their weights, you take their blood pressures, and refer where you can't manage. It's very, very important. And also, let's improve our communication when we are communicating to these mothers. Let them know what you found out when you've examined them, what is the way forward, and most importantly, let's do birth plan. Let's have birth plans. We do this and we prepare our mothers that they don't just come when they are in a very critical state. Thank you very much.
All right, thank you very much, the team online, for actively participating in this CME. Take home, PET is treatable. It can be when detected early. It can also be preventable. So as a team, we should join hands and fight any death of a mother or a baby from pre-eclampsia.
Thank you so much, Dr. Cheyude. Dr. Ndoziro.
All right, thank you very much. We are so delighted to have heard this. Information is power. My take home, someone asked the question, what is the take home message for non-medical people? First is please attend antenatal. When you get pregnant, as soon as you realize you're pregnant, go to hospital, because you don't know, you might have any of these diseases we talked about that give you a very high risk of getting preeclampsia. So kindly go to hospital. Then the health workers, when the patients come, you do not just go through things routinely. Go do scan, go do this, go do that, and then you do not interpret the results. Have the results interpreted. Know that this is a blood pressure. Last time it was this. Dr. Jackie said, use reference. You have your initial blood pressure, then it has gone up slightly. Take notes. If you've done your analysis and you realize someone has urine protein, that should not be there. So take note as well. And listen to the patients. They will tell you they've had a headache, they have a gastric pain. Do not treat every gastric pain in a woman as PUD, because we've had mothers who have been treated as PUD until they convert and realize it was actually pre-eclampsia. So take home is that we can do this, both the health workers by being vigilant, the non-health workers or the mothers who are out there by attending to your antenatal contacts. Thank you very much.
Thank you so much. Dr. Jackie.
For me, thank you, Khadija. Thank you so much, online team. For me, the take-home message is medical or non-medical, we are all champions, and we can only fight this together. The awareness is not done. We are all going to continue awareness wherever we are. Each time you see a pregnant woman, ask her if she has had her blood pressure taken. And even you, when you're pregnant and you go to a facility, demand for your blood pressure to be taken. This in antenatal. I welcome all of you to the CME for Augu on Tuesday. If you really want to go into the molecular discussions on pre-eclampsia. Thank you so much. We hope to see our numbers go down. We want to leave the position for other conditions. For pre-eclampsia, our target come below 8 of maternal deaths by next year. Thank you.
Yeah, I just put my foot down, stand up, opening like this.
Thank you so much, Dr. Thank you so much, the experts, for those wonderful last words. But of course, for me, many of you people know me for postpartum hemorrhage. So I joined the discussion for PET because I know if we have low numbers of PET, we are going to have very low numbers of PPH. So that's why I really joined the discussion. So colleagues, please, we asking and requesting you to put on your camera so that we have a screenshot. Want to see your faces. We want to take a photo, but as we are taking the photo, I cannot thank our participants enough for being part of this. Ministry of Health, thank you so much always for the guidance. And of course, the experts, thank you so much. Seed Global, thank you so much. PET subcommittee, thank you so much for leading this work in the awareness and everything about PET. Our participants are critical cadres, doctors, obstetricians, nurses, clinical officers, the young midwife leaders. We have young doctor leaders. Yes, thank you so much, everyone, for logging in. Yeah, so we are in this together, and we know with all combined efforts, we shall be able to really curb down the number of cases for PET. Please put on your cameras. We want to see your lovely faces.
Hello. Thank you for attending.
Thank you so much for attending. And of course, let's get geared for August for postpartum hemorrhage. Thank you. And yes, August is PPH month. So Dr. Andre, are we done?
So we'll have the next session in 2 weeks' time.
Okay.
It will be on gynecological emergencies.
Okay.
We hope to see everyone again in 2 weeks' time. Thank you once again for sharing.
Okay, so with the powers entrusted to me, I want to call off this session and bye-bye to everyone.
Bye.
Thank you.
Bye. Thank you too. Bye. But none thank to the moderator. Okay. Thank you.
Yes, we are tired. Oh, umuntu watumye Let's take back my stand.